Today we are going to discuss about one of the important topics in orthodontics, that is anchorage. What is anchorage? Anchorage is nothing but a resistance to unwanted tooth movement, or we can call it as nature and degree of resistance to displacement offered by some certain anatomical units when we are planning or thinking of moving a single tooth or a group of teeth. That means anchorage is nothing but a support from which we can apply force to move a single tooth or a group of teeth. Now, why do we actually need anchorage? What is the purpose of anchorage in orthodontics? For example, I can't move myself, or to simplify the thing, if you want to move a tooth, the tooth does not move by itself. It has to be pulled from some source so that the tooth will be moved in a desired position. This support from which we are applying a force is called as anchorage. This is according to Newton's third law of motion. Every action has an equal and opposite reaction. So when we are trying to move a tooth or a group of teeth by taking support from some other components, the forces will not only act on the tooth or a group of teeth that are moving, but the forces are also exerted on the supporting structures or the anchorage unit. Okay. Now, for orthodontic treatment, we should plan anchorage in such a way that the anchorage units are held in their position itself without allowing them to move, at the same time applying force through them in order to move the tooth or a group of teeth whose movement is intended. Clear? Now, let us look into the classification of anchorage. We can classify anchorage based upon different criteria. Based upon the manner of force application, we can classify anchorage into simple anchorage, stationary anchorage, or reciprocal anchorage. The second way of classifying anchorage is based upon the jaws involved. It might be an intermaxillary anchorage or intramaxillary anchorage. The third way of classifying the anchorage is based on the site of anchorage, whether the anchorage is present intraorally or extraorally, or we are taking anchorage from the muscles. Yet we have another way of classifying anchorage based upon the nature of anchor units, whether it is a simple, compound, or reinforced. Let us discuss each of these types of anchorage. First, what is simple anchorage? A simple anchorage is nothing but we are taking support or anchorage from a group of teeth in order to effect single tooth movement or tipping movement of a teeth. So the anchorage which we use in order to move a single tooth to bring about tipping movement is called as simple, or the affecting tooth movement is tipping movement here, and we call it as a simple anchorage. Now, the root surface area of the anchorage unit here should be double the root surface area of the tooth that is to be moved. Okay. What is stationary anchorage? The anchorage which we take in order to move a tooth or a group of teeth in a bodily fashion is called as stationary anchorage. Here, the number of teeth that are involved in the anchor unit are more than the number of teeth that are used for simple anchorage. What is reciprocal anchorage? Reciprocal anchorage is nothing but we are taking support from anchor unit in order to move a tooth, and in turn the tooth that is being moved also act as anchor unit to move the other tooth. That means We are applying forces between two teeth or two groups of teeth wherein both the groups of the teeth or both the teeth move towards each other in order to close the space or open up the space, whatever it is. Here we have two groups of teeth and both the groups of the teeth will be moving towards each other. This is called as reciprocal anchorage. Now what is intramaxillary anchorage? If we are using anchorage from a group of the teeth in a particular arch, whether it be a maxillary arch or be a mandibular arch, and we are using the group of teeth in one arch to move the tooth or a group of teeth within the same arch, then it is called as intramaxillary arch. That means both the teeth that is moving as well as the anchorage teeth are present within the same arch. Whereas in the intermaxillary anchorage, we are taking support from a group of the teeth in one arch to move the teeth in the opposite arch. For example, if we take a group of teeth in the mandibular arch to move a tooth or a group of teeth in the maxillary arch, then it is called as an intermaxillary anchorage, and in one or the other way it also comes under reciprocal anchorage. Now, based upon the site of the anchorage, we can classify anchorage as intraoral anchorage or extraoral anchorage or muscular anchorage. What is the intraoral anchorage? Anchorage that is taken from the sites within the oral cavity are called as intraoral anchorage. That might be a tooth or a group of teeth, alveolar bone or the basal bone, okay, or by using muscles, the mentalis muscle via lip bumper also comes as a intraoral anchorage. Now, what do you mean by extraoral anchorage? In the extraoral anchorage, we take support from the structures which are present extraorally, like parietal bone, occipital bone, frontal bone, okay, or nape of the neck or facial bones can be taken as an anchorage to move the tooth or a group of teeth or a skeleton, as in case of orthopedic appliances. What is a muscular anchorage? It's nothing but anchorage taken from the active muscles of the craniofacial skeleton. For example, if you want to move the lower molar, permanent molars which have been tipped mesially into the exfoliation space of the deciduous second molar, we'll fabricate something called as lip bumper, which has an acrylic component in the labial vestibule in the lower arch, in the lower jaw, labial vestibule. Due to the hyperactivity of the mentalis muscle, the forces of the mentalis muscle will be placed on the tipped lower molar, thereby pushing them distally. So here we are taking the activity of the mentalis muscle to push the lower molars distally. This type of anchorage is called as muscular anchorage. Now, another view of taking intraoral anchorage is by placing a mini screws within the alveolar bone, which we will be discussing in the next slides. Now, based upon the number of anchorage units, we have anchorage as a simple, compound, reinforced. What is meant by a simple anchorage? Here, we are taking support of single tooth for the movement of the other tooth. But the root surface area of the single tooth which is used as an anchor unit is more than the root surface area of the tooth that is being moved. This is called as simple anchorage. Now, what is the meaning of compound anchorage? Compound anchorage is nothing but for movement of a single tooth, we are taking support from a group of teeth. This is called as compound anchorage. What is reinforced anchorage? It is nothing but we have two groups of teeth. One is anchor unit and one is the unit that is being moved. Apart from the anchor unit, we are supplementing the anchorage by using other appliances like headgears or transpalatal arches or lingual arches to reinforce, that means to augment the anchorage that is already existent in order to move the group of the teeth. This is called as reinforced anchorage. The maxillary incisor is being forced buccally or labially by using a spring that is embedded in the acrylic plate. Here the acrylic plate gives, it takes support from all the teeth in the maxillary arch to push a single tooth labially. This is an example of simple anchorage. That means the tooth that is moved, the unit that is moved is a small, whereas the unit that is used as an anchorage is a very much bigger unit. The second one is stationary anchorage. Here in the second image you can actually observe premolar and molar are used as anchorage in order to move the canine to canine segment. But this support or this anchorage might not be sufficient to move the group of 6 anterior teeth. That's why here they have used a transpalatal arch reinforcing the anchorage. So a reinforced anchorage is usually a stationary anchorage which is used to stabilize the anchor unit. That means the anchorage units should be absolutely stay in their own place while the forces are being applied from them to move a group of teeth. This is an example of stationary anchorage. Intramaxillary anchorage, wherein both the anchor unit as well as the tooth that are being moved are present in the same arch, whereas the intermaxillary anchorage situation is that situation where the anchor units are present in one arch, whereas the tooth that are being moved are in the another arch. Class 2 elastics, class 3 elastics are an example of reciprocal anchorage or intermaxillary anchorage. We even call them as Baker's anchorage. This is one more example of intraoral anchorage, wherein we take this is a diagonal elastic that has been passed from canine in the maxillary arch on one side to the canine in the mandibular arch on the opposing side. This is a diagonal elastic usually used for correction of the midline shift during fixed orthodontic therapy. It comes as a reciprocal anchorage in one way, intermaxillary anchorage in another way, and intraoral anchorage in the other way. See, the classification is mainly for our understanding. It's not that a classification is completely a different type of anchorage. See, for ease of understanding, for our convenience, we have classified the anchorage. But frankly speaking, as you see here in the first image, it's a diagonal elastic. It comes under reciprocal anchorage, intermaxillary anchorage, intraoral anchorage, as well as a compound kind of anchorage. Now, the second thing is extraoral anchorage. Here we are taking support from the occipital region or parietal region or nape of the neck or the back of the neck in order to affect movement of teeth or jaws. So all the orthopedic appliances can be used as extraoral anchorage. Now, when these extraoral anchorage systems are used in combination with the intraoral anchorage systems, then this is called as a reinforced anchorage. That means a reinforced anchorage has the anchorage sites at 2 anchorage sites, whereas a normal anchorage has only 1 anchorage site. Just remember and note it down. Reinforced anchorage here. One more example is the bite plane. Okay, and it's also an inclined plane. Whenever the mandibular incisors tries to occlude with the anterior bite plane, the mandibular incisor will try to go back into its normal place. That means the mandible will try to move back, but the inclined plane here restricts the movement of the mandible backward, and this force of restriction will be transmitted in turn to the maxillary teeth. This is a means of reinforced anchorage. Now, the two images, the springs to close midline diastema, wherein both the central incisors move towards each other to close the midline space, an example of reciprocal anchorage, and the cross elastics to correct the single tooth crossbite, which we place from the parietal of the maxillary arch to the buccal of mandibular arch. Whenever the person opens and closes the mouth, the elastics will produce a reciprocal force on both maxillary molar as well as mandibular molar. Not only in the molar, if we have a single tooth crossbites, we can use cross elastics anywhere in the oral cavity. Now, apart from the general classification, there is one more type of anchorage that is being utilized nowadays is absolute anchorage. What is an absolute anchorage? It's nothing but when it's a type of anchorage where there is no anchorage loss. That means there is no movement of the anchorage unit. Usually, when you use a group of teeth for movement of another group of teeth, there will be some amount of movement of even anchorage unit, however large the anchorage unit may be. But in absolute anchorage, we will be using something called as mini screws or mini implants, which are placed into the bone to be used as anchorage unit. So we will exert force via elastics or any kind of force applying agent. We will be stretching it from this implant, which is used as anchorage unit, to the tooth or group of teeth that is being moved. Here the implants will produce an absolute kind and 100% anchorage without moving by themselves. That means maximum resistance to movement due to the reciprocal forces will be exerted by these mini screws or mini implants. Here you can see the mini implant has been placed in the middle of the palate. A transpalatal arch is being used, which is attached to the molar, and elastics are placed from the mini implant to the transpalatal arch that is been attached to the molar in order to cause intrusion of the molar. Not only in the intrusion, we can also place mini implants between the two molars, both in the upper and lower arch, or between the first molar and second premolar, or in the midline between two incisors to intrude the incisors, or in the midline between the two incisors in the lower arch to intrude the lower anteriors. So depending upon what type of tooth movement, you can use implants judiciously at different intraoral sites to be used as an absolute anchorage units. Now, we know about what is anchorage, what are the different types of anchorages, and how one anchorage system varies from the another anchorage system. Now let us look into the factors that factors that affects the anchorage. Number one is teeth. Number of teeth. Suppose an anchorage unit having more number of teeth will provide more support or provide more anchorage when compared to the anchorage unit having less number of teeth. It's obvious. More number of teeth implies more number of roots, more root surface area, more anchorage. Less number of teeth implies less number of roots, less anchorage, less root surface area, and less anchorage potential. Now coming to the root forms. Root forms of the teeth might be either round, flattened, or triangular. The triangular root forms offer most resistance to the deleterious forces. That means the more triangular the root of the anchorage unit is, the more resistance it offers. So the maxillary canines are the roots whose length is also long, whose cross section is also triangular, and they offer maximum resistance to tooth movement. Whereas the roots of the mesial roots of the maxillary molars and the mandibular incisors, okay, they offer less resistance to tooth movement when compared to the maxillary canines. Okay, the basic concept is the triangular roots have larger root surface area and more periodontal ligament fibers getting attached when compared to the round roots and flattened roots. Okay, now coming to the size and number of roots. The larger the size of the root, more will be the anchorage potential. The more the number of roots, more will be the anchorage potential. For example, maxillary first permanent molar provides more anchorage resistance when compared to the mandibular first permanent molar. Why? Because maxillary first permanent molar has 3 roots. That is due to tripod effect. It offers more resistance to tooth movement when compared to the mandibular permanent molars. Now, root length is one of the factors that affects the anchorage potential. The longer the roots, the more will be the root surface area and more will be the anchorage potential. The smaller the roots, the less will be the root surface area and lesser will be the anchorage potential. Similarly, position of the tooth within the dental arches also has an effect on anchorage potential. For example, when we take maxillary first and second molar, they are present between 2 strong cortical plates in the mandible. That is why they offer more resistance when compared to the mandibular premolars or incisors, whatever it is. So the more the cortical bone supporting a group of a teeth, the more will be the anchorage provided by those group of teeth when compared to the teeth that are being covered by cancellous bone. One more important factor that affects anchorage is inclination of tooth, inclination of anchor tooth. For example, if the anchor tooth is inclined, that is tent pegged, we call it as inclined, then it offers more resistance to tooth movement. For example, if we are moving a tooth in one direction and the anchor tooth is bent in the opposite direction, then it provides a more anchorage when compared to a straight tooth. Similarly, tooth with delacerated roots provide more anchorage when compared to the normally inclined or straight roots. Even the teeth that are ankylosed are strongly resistant to movement, similar to as you see in case of absolute anchorage. Even the musculature, the more active the muscle, the more will be the anchorage potential. For example, in case of hyperactive mentalis muscle, it provides much anchorage. That means the muscle force is transmitted via some appliance like the bumper to the teeth in order to move the tooth. Similarly, basal bone, the more cortical nature of the basal bone provides more anchorage. We can place mini screws or mini implants in the basal bone in order to move a tooth or a group of teeth. These mini implants can be placed in the region of tuberosity in the maxilla, or we can also place it in the region of retromolar area in the mandible. Similarly, as I told you previously, we can place the mini implants between the roots of the teeth, either between two permanent molars or between first permanent molar and second premolar, depending upon the type of tooth movement or the direction in which the teeth has to be moved. Now, the extraoral anchorage. Extraoral anchorage can be taken from either the occipital region, parietal region, or frontal region, or from the back of the neck. So, depending upon the direction of the force application, the teeth can be moved by using support from extraoral structures. Yet, we have another way of classification of anchorage clinically. This classification was proposed by Dr. Ravindrananda. We have different types of anchorage according to this as maximum anchorage, moderate anchorage, and minimum anchorage. We can also call it as Group A anchorage, Group B anchorage, and Group C anchorage respectively. Let me explain it in a detailed fashion. For example, if we have a case of extraction treatment, like we are extracting all 4 first premolars for orthodontic treatment. Now, depending upon the type of correction we require, for example, if a patient has severely proclined teeth, we need to take the teeth as much as possible into the extraction space. That means we should not allow the anchorage units to move into the extraction space. Even if we allow the anchorage units to move into the extraction space, it should be very minimum of only 1/4 of the extraction space. This type of anchorage is called as maximum anchorage. That means the extraction space is completely closed, or 75% of extraction space is closed by interaction of anteriors and allowing only 25% of mesial movement of the anchorage unit. This is called as Group A anchorage. Now, coming to moderate anchorage or Group B anchorage. Here, we allow 50% of extraction space to be closed by anteriors and 50% of the extraction space to be closed by anchorage units, that is posteriors. This is called as Group B anchorage, moderate anchorage, or symmetrical space closure. Now, what is minimum anchorage? Minimum anchorage is also called as Group C anchorage. It's nothing but we allow 75% of the extraction space to be closed by mesial movement of the anchorage unit, that is by anchorage loss, and only 25% of the extraction space is utilized for closure of the space by distal movement of the anteriors. That means in cases where we need much amount of space to be utilized for retraction of anteriors, we use maximum or groupie anchorage. Whereas in cases where extraction space might be half closed by anterior retraction and half closed by ankylosing loss, that is posterior protraction, then we will be using as we will be using moderate or groupie kind of anchorage. Whereas in cases where the space requirement for distal movement of anteriors is very less, then we will allow the extraction space to be closed by 75% by movement of the posterior and 25% by movement of the anterior. This is called as group C anchorage. Clear? Now, how will you notice the anchorage loss, or what are the features that give you an idea that the anchorage unit are moving, the anchorage is being lost? Here are some features like change in molar relationship. For example, during the beginning of the treatment, if the molar relation is class 1, and during the course of the treatment, if the molar relation is getting into class 3 or class 2, then you can say that there is anchorage loss in either the mandible or maxilla depending upon the type of molar relationship. For example, if in a class 1 molar relationship patient, during the course of the treatment, as the treatment progresses, the molar relation is tending into class 3 or moving into class 3, then there is more anchorage loss in the lower jaw. On the other hand, if the molar relation is getting more into class 2, then there is anchorage loss in the upper arch. So based upon the change in the molar relationship, you can assess the anchorage loss. Now, closure of extraction spaces by mesial movement of the posteriors is one more factor that can be used to assess the anchorage loss. Now, in some cases, during the course of orthodontic treatment, due to inbuilt features in the brackets of straight wire appliance, we can have the upper anteriors or lower anteriors being flared or proclined. That means the proclination actually was present before the treatment will be still more aggravated during the course of the treatment. This indicates that there is an anchorage loss. Sometimes spacings between the anterior teeth or between the posterior teeth occur as a result of anchorage loss. For example, in the case of extraction treatment, during the process of space closure, if you see that the space is occurring between distal surface of the first molar and mesial surface of the second molar, then it indicates that the first molars are being moved into the extraction space, thereby leaving up space between the second molar and first molar. This is also one of the indication that anchorage is being lost. Now, one more characteristic feature of the anchorage loss is increase in the overjet. As I told you, due to more flaring or proclination of the teeth during the course of the treatment, the overjet will be increased. And anchorage not only means in the anteroposterior space, but it also means in the vertical space and transverse space. The anchorage loss in vertical space might itself appear as opening up of the bite or closing up of the bite, and the anchorage loss in the transverse plane will itself result as either constriction of the arches leading to mandibular buccal crossbite or expansion of the arches leading to maxillary buccal crossbite. Okay, so during the course of the treatment and right from the beginning of the treatment, you have to assess the anchorage requirement of a case clearly. You should plan the anchorage right from the beginning of the treatment so that you will not land up in complications throughout the treatment. Okay, so anchorage is very much essential. Anchorage preparation is very much essential for each and every case. So plan your cases with good anchorage so that your treatment will be a great success. Thank you.